Hi, this is Evan Blake for the Global Workers Inquest into the COVID-19 pandemic. Today, we're joined by data analyst and healthcare expert, Gregory Travis. Thanks for joining us today, Greg.
My pleasure. Thank you, Evan.
Greg will be giving a presentation on the issues surrounding data manipulation and cover-up in the United States during the pandemic, as well as the issues surrounding school reopenings and the impact of COVID-19 on children. Greg, would you like to begin your report?
Sure. Yeah, as you mentioned, my focus recently has been kind of on the collapse of COVID surveillance that's going on right now. It's particularly acute right now. What we're seeing is basically states, counties, the federal government, hospitals, basically everyone is going into a mode of withholding or not even collecting data, basic fundamental statistical data about COVID, such as the number of cases, the number of hospitalizations, the number of deaths, et cetera. And the other thing that's going on in parallel with that is kind of a redefinition of a number of fundamental terms, terms like COVID itself. What is COVID? What does it mean to be infected by COVID? What does it mean to be hospitalized by COVID? What does it mean to die from COVID? All of those definitions are very fluid at this point, and they're all being revised essentially to remove as many deaths, cases, hospitalizations as possible from the category of being caused by COVID. This is a bipartisan, if you will, effort. It doesn't really cross party lines. Both the Democrats in power and political leadership, as well as Republicans, and especially the previous administration, are doing it and have been doing it. And it's quite troubling. And I'll talk about this a little bit later, but one of the areas where it's particularly troubling is with regard to COVID and children. Early on in the pandemic, a myth was promulgated, and I'll talk a little bit about this, that children were essentially immune to COVID, if you will. There was no data that supported that at the time, and in fact, the data that we have now says quite the opposite. So with that as kind of an intro, I'll go ahead and get started here. This is a slide just of some things I picked off the web, and kind of an example for that. In the middle are a couple things. One thing I pulled off of Twitter. Another thing that came out that's kind of talking about the backlash. There's a kind of a growing backlash. I think, Evan, your organization has done a great job of this. This really pushing back on this emerging narrative that COVID is going away because we're not counting it anymore. And people are becoming quite upset about that. But I want to point out that this is not a recent phenomenon. It goes all the way back to the previous administration. President Trump then famously said, I think it was back in summer of 2020, that we should essentially just stop counting COVID cases. That's something that the current administration has actually echoed and re-amplified in recent days. So this notion that we don't need to count is a pervasive one and a relatively pernicious one. Some of the early stuff that we saw in terms of trying to downplay the severity of COVID, downplay the impact on society, was comparisons to the flu. Comparisons between COVID and the flu have always been and continue to be rampant. Early on, we were told that it was just like the flu, and that it shared a lot of flu's fundamental characteristics, the biggest one of which would be flu's seasonality. Influenza typically tends to blossom between October and March in the Northern Hemisphere, and it blossoms in the Southern Hemisphere on the 6 months after that. And this has to do with characteristics that are fairly unique to influenza itself. They're not necessarily intrinsic characteristics of all diseases, and in particular, even all respiratory diseases. And I want to correct myself there. COVID is not a respiratory disease. It's often called a respiratory disease, but it is not. It is a systemic disease, particularly of the vascular system. So it comes in through our mouth and through our nose. And so it generally sets up shop first in the areas of our bronchial tubes and our lungs. But that doesn't make it a respiratory disease any more than the fact that we get polio infections coming in through our mouth makes polio a disease of the mouth. It is a systemic disease. It affects and damages virtually every organ in the body.
Greg, if I could pause you for just 1 second. I know there was I believe it was in April 2020, there was an influential study published by John, I think his name is pronounced Ioannidis, and Jay Bhattacharya, basically making this false comparison between COVID and the flu. I was wondering, are you familiar with that? And
yeah, I actually commented on that. The first incarnation of that was the so-called Santa Clara study. And in the Santa Clara study, I don't remember the exact numbers, but they came up with what we call an infection fatality rate. And maybe I should make a little distinction now. We have what are termed case fatality rates, and we also have what are termed infection fatality rates. A case fatality rate is the rate of death among known cases. Cases are generally symptomatic for all diseases, because if you don't have any symptoms to a disease, it's unlikely that you're going to get tested for it. You don't even know that you have it. So, a famous example, again, I like to use polio a lot. Polio is 75% asymptomatic, truly asymptomatic. 75% of people who were infected with polio never knew that they had been infected. Their bodies took care of it and it went away. There were some people who became, because of their condition and their symptomatic reaction to polio, became polio cases. Cases are essentially those individuals who've been infected with a pathogen who come to the attention of the system, if you will. So that's what the case fatality rate is. The other is the infection fatality rate. Infection fatality rate is simply how many people who are actually infected with a given pathogen, in this case, it would be the SARS-2 pathogen, who die from it. That's much harder to calculate, again, because most diseases, most pathogens, when they infect people, don't produce any symptoms. People are often surprised by that, that just because you're infected with something doesn't mean that you're going to develop symptoms. About 70% of people who are infected with the influenza virus never know that they've been infected. They get infected and then it goes away. About half of all people who are infected with hepatitis don't know that they've been infected. So it is very difficult to calculate an infection fatality rate because it's very difficult to know how many people are actually infected with a pathogen. Now, to get back to what we were talking about earlier, John Ioannidis did something called the famous Santa Clara study, which was an opt-in study. I think they advertised for participants on Facebook and other places. So it had some real problems in terms of the pool of individuals that were being studied. But long story short, he came up and he basically said the infection fatality rate of SARS-2 is somewhere in the range of 0.2%, which sounds very low. And I don't know if he did it in that paper, but there was also then comparisons between the 0.2% infection fatality rate of SARS-2 and the 0.2, 0.3% case fatality rate of influenza. Again, that's comparing apples to oranges. Influenza has somewhere, we don't actually know, but it has somewhere around an infection fatality rate of 0.03%, not 0.2, not that. So even then, if you compare the infection fatality rates of influenza and COVID was about an order of magnitude higher. Yep. But the real problem with Ioannidis' study was when he said that Santa Clara, based on his study in Santa Clara, that the infection fatality rate was somewhere around 0.2, 0.3% of the entire population of New York City had already died. So that's something we call the population fatality rate. How many people out of a given population have already died from a disease? It doesn't count people who are infected, doesn't care if they're infected or not. It's just if you have a population, let's say a town of 10 people, and one person dies from a given disease, that disease has a population fatality rate of 10%. Now, Ioannidis said that the infection fatality rate, which can never be mathematically larger than the population fatality rate in Santa Clara, was 2.2%. And this was at a time when 0.3% of the entire population of New York City had died of COVID. And people noticed that very rapidly. And it was brought up to Ioannidis. It was also brought up to Sunetra Gupta. And their response was essentially to wave their hands and try and find out and try and invent some reason why both the infection and the population fatality rate in New York City could be so much higher than it was in Santa Clara, that didn't go back to the fact that Santa Clara was simply much less infected than New York City.
Right.
So that's my take on that study.
Yeah.
Since then, Ioannidis has continued to publish paper after paper, and comes up with for other geographic areas, including the world, basically ridiculously low IFR numbers for COVID, and easily disproven.
Yeah.
And when pushed on this, he, from what I've seen, becomes quite angry and belligerent about it,
Yeah.
and it falls back on essentially credentialism and the fact that he's had more scientific papers published than God.
Right. No,
So.
it's unfortunate. I mean, I know he, before the pandemic, had been, very highly regarded and actually had done important research on bias in scientific research.
Yeah.
Yeah. But I mean, this study, the Santa Clara study, sort of set the tone for comparisons between COVID and the flu from then on, essentially, right?
Right. And it was and it's stuck with us ever since. One of the I won't say unfortunate facts, but one of the things that we deal with is that most people, particularly in the United States, have no firsthand experience with disease of any kind. Most people have no real experience with hospitalization, simply by virtue of the fact that the younger you are, the less likely you are to need medical care, the less likely you are to have had a serious disease of any kind, the less likely you are to have gone to the hospital. So most people's experience with disease is pretty much limited, and by most people, what I mean are people who are younger than me, people under 50. People under 50 generally don't die, and they don't get sick. Of course, there are counterexamples, but that's the general rule. So when people heard of this new disease, COVID, they had nothing to compare it to in their own experience. The only thing they really had to compare it to was having a head cold, or a headache, or maybe diarrhea, or at worst the flu. I'm 58 years old, and I can count the number of times that I've had the flu on 2 fingers.
Yeah.
And most people don't get the flu, but people naturally were looking for ways that they could relate their own experience to this new disease. And so they were very ready to accept that comparisons of COVID to the flu, because that's the only thing they had any experience with. And so when people started coming out and saying, well, it's like the flu, and in particular, that it's seasonal, like the flu. Again, flu has a very strong, most diseases exhibit some kind of seasonality. We don't really know what imparts seasonality to a disease, but most diseases, even cancer, are more prevalent at certain times of the year than others. Influenza tends to be very prevalent from, again, October through March in the Northern Hemisphere. And so when people heard that COVID was the flu, they also made an assumption that since they typically got colds in the winter and they got the flu in the winter, that COVID would be something that was, basically only a problem in the winter. And the thing that this set up for us was that it set up all of our policy and really all of our public health reaction apparatus to dealing with what even experts thought was going to be something seasonal, like the flu, that would come and hit us pretty hard, around Christmas and the first of the year. And so, and we heard, the Trump administration say that, Trump famously said it'd be gone by Easter. And here we are, 2 Easters later, and it's still around. But they thought, it would go away in summer. I remember thinking it would go away in summer at all as well. And then in 2020, we had a huge wave of COVID throughout the American South, from Florida to Arizona, that didn't get really a whole lot of headlines. So we've been really hobbled, both in the public's perception as well as the response by public health officials, by this notion that COVID is it's a respiratory disease, which it's not, and it's just like the flu, which it's not. It's not even the same viral family as the flu. Again, it's a pathogen that causes a disease primarily in the vascular system and causes damage to virtually every organ in the body if given a chance. So that was a big problem. The other big thing that kind of came out early was a number of people expressed surprise at the age gradient of COVID. They said, oh, it's only old people that seem to be vulnerable to it. And that's true. The older you are, the more likely you are to have severe disease or to die from COVID than if you were younger. But that isn't something that's actually unique to COVID. Virtually all diseases exhibit a very similar age profile.
Yeah.
For instance, the median age of a cancer death is 70 years old. There are around 650,000 cancer deaths a year. Of that 650,000, less than 2,000 happen to people under 18 years of age. So the thing, and most people, again, because most people don't have much experience with disease, that wasn't intuitive to them. So when they heard people say, well, COVID really doesn't seem to affect children, but it does seem, but what it is, if you're old, you're in a nursing home or whatever, it really hits those people hard. What people internalized was, this is something unique to COVID, right? Unlike other diseases, COVID doesn't affect children. And so that also led to a great relaxing of really effort. People said they thought in their minds, and experts confirmed this, only old people are at risk. And this will come up a little bit later in what I'm talking about with regard to the Great Barrington Declaration. But young people don't have to worry about it. So if you're young, go out, have fun, hang out in the bars, etc., because you're not likely to die from it. Yeah. Which is true. But again, it's true of everything from cancer to polio, frankly. So that was a big problem that we early on, and then we expanded on that, and I'll talk a little bit actually maybe about this little thing, which is something that was related, that they said, well, only people with comorbidities have it. Yeah. That again was this kind of inequitable carving off, an attempt to carve off a demographic that was vulnerable to COVID, but that was very small. And that was a great disservice to us. So, and I'll talk about that in just a little bit.
When we're discussing the question of the flu, just reminded me of the the Woodward revelations from September 2020. I don't know if you recall this, but this was when Woodward was about to publish his book. He finally revealed that in January and February 2020, he had private phone conversations with Trump. And one of the most significant was on February 7th, Trump told Woodward that he had just spoken with the Chinese president, Xi Jinping, who told Trump, or what Trump told Woodward, quote, based on that discussion, he said, quote, "This is deadly stuff. It's also more deadly than even your strenuous flus. This is 5%, referring to the case fatality rate, versus 1% and less than 1%. He also later on, after another discussion, he told Woodward, "It goes through the air, Bob. That's always tougher than the touch." So this was very explosive when it came out in September, but clearly Trump knew as early as February how dangerous this was. That he said it himself, that it's worse than your strenuous flus, but this was covered up. So I guess maybe if you could speak to that and just sort of your thoughts on that revelation.
Yeah. This again, this theme of I'm not sure I'm quite ready, but I'm very close to calling it a cover up. Is pervasive. It crosses party lines. It crosses all kinds of lines, and it's still unclear to me the reasons for the cover up. I think that one legitimate reason that I'm sure goes through certain people's minds is that if we tell people how bad this thing really is, they're going to freak out.
Yeah, that's what Trump said. He said, I always wanted to play. He told Woodward, "I always wanted to play it down. I still like playing it down because I don't want to create a panic." And
right,
what main panic he was referring, panic on the stock market, which came in February and March. There was a massive, decline in the stock market until it was bailed out with the CARES Act.
Yeah. And I think there are people of goodwill and who are honest brokers who do honestly believe that if from what they know, that if they were forthcoming with what they know, that it would cause a panic and it would be unproductive. I don't share that view myself. I've always found that I'm more comfortable being told the truth. Because it's empowering, frankly, to know, okay, it's airborne, it's incredibly easy to get, and by the way, if you get it, even if you get a mild case, you might have permanent brain damage.
Right.
That might make some people panic but I believe, and this is based on people I talk to, people would rather hear that because again, it's empowering. Okay, I know I've got to limit my contacts as much as possible, right? I've got to make demands of my workplace that we restructure work in a way that minimizes transmission, right? I've got to put my foot down about that. I've got to make demands, if it really is as bad for children as it looks like it will be, that the way that we deliver education changes fundamentally in a way. And when people are given that information, they can make those kinds of plans and they can make those changes, and those changes as a side effect will have the very beneficial economic effect of reducing apprehension, reducing confusion, and restoring order. I won't say normalcy, but restoring order. This is another slide I just wanted to kind of show again how we've co-opted terms and we've changed terms to kind of refit a way. One of the terms that came out early on and just is relentless, it continues to be used with abandon, is this term mild. Whenever you hear people talking about COVID, it is going to be a rare day in hell when you won't hear the term mild interjected at some point. Mild has a very distinct clinical meaning. A mild disease or a mild course of disease is simply one, this is according to the WHO's and the CDC's guidelines, is simply one that doesn't require hospitalization.
Right.
Now, I didn't go to the hospital the 2 times that I had flu, but I wasn't getting out of bed either.
Yeah.
You know, I couldn't drive, I couldn't do anything, and I was as sick as I've ever been. But clinically, I had a mild case of the flu, and that was just in its acute phases. I may have had, lasting systemic damage from the flu that didn't even manifest itself as symptoms. So we hear this term mild, and we need to be careful to understand that mild simply means not hospitalized. And I think that most of us who, I've never been hospitalized. Well, I got cholera when I was an infant in India, but that was the only time I was hospitalized, i.e. spent the night in a hospital. So it's very difficult for me to conceive of something being mild simply by virtue of the fact that I didn't have to get hospitalized for it. But nonetheless, that's what happened. The other thing.
Well, I was just on that. Sorry to interrupt. Just
no, go ahead.
The term mild. I mean, it's been most associated with the Omicron. And we saw in the U.S. And many other countries record hospitalizations during the Omicron surge.
Yeah.
So even that the clinical definition is not appropriate at all. I mean, yes, there's been far more infections, so the percentage of hospitalizations is lower, but you've still had an absolute, the record number in January.
Yeah, that's absolutely true, and I'm going to talk about that a little bit. Omicron was the portrayal of Omicron or Omicron. I'm never even sure how to pronounce it, but the portrayal of Omicron as mild is probably one of the greater crimes that has been committed. And unlike some of the early stuff that happened, calling it the flu, etc. It's my position that the depicting Omicron as mild was deliberate.
Yeah, absolutely.
Omicron showed up at the most inconvenient time, right? Schools had all gone back to in-person learning, and it was a full speed ahead, damn the torpedoes approach. And then all of a sudden Omicron showed up, and it had the potential to unravel all of that. Yeah. Unless some way was found to blunt its importance in the public's eye, in which case we could continue back towards the path of quote unquote normalcy. So Omicron was, and Christmas and consuming and all that kind of stuff and getting people back to work. So I believe it was a very deliberate act to downplay the severity of Omicron, and what makes it a crime is the disproportionate effect of Omicron on the unvaccinated, particularly on children who were either unable to become vaccinated because they were too young, or were not being vaccinated because of vaccine hesitancy by their parents, who had swallowed the propaganda that COVID didn't affect children. And remind me when I kind of get into that, because that constituted, and it's still going on, essentially a generational crime.
Yeah,
absolutely. And it's a violation of children's rights. It's a violation of our adult responsibility to protect children We just, as adults, made the determination that we would sacrifice children. And it is, I still can't get my head around it to this day.
Well, I guess I would just I would say I think the people in power, those who are, control the political system made the decision. I don't think, as you said, there's been massive amounts of propaganda that, if you're an average person and you're not educated on these issues, it's very hard to break through that.
Just to kind of, again, emphasize that the bipartisan nature of this, another term that has been redefined, refactored, is this notion of endemic. I started noticing and kind of tweeting about it, I think it was late a year ago this spring, when I started hearing chatter about how COVID would transition to an endemic disease like flu again. And again, the vast majority of the public are laypersons, and they didn't know what endemic meant. So when it was equated to influenza, what they heard was that endemic means mild, because in their minds, flu is mild, colds are mild. So they were given examples of endemic diseases, colds and flus, that they don't feel threatened by in any way. And again, this was deliberate. CDC Director Walensky was on MSNBC, and the media has been unbelievably complicit in this. And it doesn't matter if it's right-wing media like Fox or left-wing media like MSNBC, they're all bringing on the same people to deliver the exact same message, and there's no pushback on it whatsoever. So Walensky went on, Ari Melber's show and said it's like that COVID was likely to become an endemic disease, much like influenza. Again, the comparison to the flu. And Melber didn't push back at all.
Yeah.
And if he'd been doing his job, what he should have said, well, wait a minute. First of all diseases become endemic. That is basically, except for a handful of diseases that have been eradicated, like smallpox, all diseases essentially settle down into an endemic condition, which is where they're just basically constantly circulating. And so it would have been just as accurate for the CDC director to have said endemic like the influenza if she had said endemic like rabies. Rabies is an endemic disease.
Right.
HIV/AIDS is endemic. Cholera is endemic. Tuberculosis is endemic. Polio in certain small parts of the world is still endemic. Bubonic plague is endemic in the southwestern United States. There are about 20 cases of plague every year in the United States. That is the definition of endemic. So again, we see this deliberate attempt to sell COVID as becoming milder, even though it's already been sold as very mild, but that in the future it will be milder still. And there's no data whatsoever to back that up. Diseases do not become milder with age. They do not become milder as they become less novel. Basically, flu has had the same severity for hundreds of years. It has not become milder. Polio, my favorite example, was endemic in the United States from 1890 to 1960. 70 years it was endemic, and it never became milder, and we never developed herd immunity to it. So we're being told that COVID is somehow both the same in that it's intrinsically mild, as well as different from all other diseases, that it will get milder in the future, when there's no evidence in history that tells us that diseases do that.
Yeah, I think it was significant that was taking place also, as you said, at the peak of the Omicron surge, in January, when there were, some days over 1 million cases. You reminded me, there's one, Ashish Jha, who's now, replacing the multimillionaire Jeff Zients as the head of the Biden administration's COVID response team. Said on January 17th, when, a day when over 800,000 Americans were infected with COVID, he said, quote, "I'm hoping Omicron gives us the lessons we need to manage the rest of this pandemic, however long it lasts, and move to a new normal where we treat this virus much more as an endemic thing. So I'm hoping this really is the transition variant that gets us into a different footing for future variants and lets us manage them more effectively," end quote.
Yeah.
Now we have BA2, it's just completely unscientific.
It's not only unscientific. One of the things that I've noticed among the experts, particularly in healthcare, is that, as far as I can tell, of all the prerequisites that you have to have in order to become a master of public health, or a medical doctor, or an epidemiologist, or a virologist, the one thing you don't have to have any background in is history.
Right.
And I don't know how Jha could have said what you just quoted him as saying, although I know he said it. But I don't know how you could say that it's going to become endemic when anyone who's taken a freshman history class, again, knows that polio was endemic for 70 years. And each successive wave every year was essentially worse than the wave before it. And so, you can imagine, time travel Jha back to 1950 and have him say, we're going to manage polio as an endemic disease. Right? We certainly didn't do that. We created in the 1930s the March of Dimes.
Right.
Specifically to publicize the effect of polio on children. The March of Dimes was publishing pictures of kids in iron lungs in Life magazine every week.
Right.
Until we did something about it.
No, we fought to eliminate it. Once
they fought and strove for 20 years before they were able to develop a vaccine for polio. But they never gave up. They never said, it's just going to let it rip.
Right.
It was constantly in people's minds, and they were constantly working to mitigate it. So again, the things that the experts are saying with regard to the age gradient, with regard to comparisons to influenza, I studied history in college, and I'm just struck by it. Do you not know about anything that happened prior to, let's say, 2 years ago? Right? The same thing was true with when this notion that's promoted in the Great Barrington Declaration of herd immunity came out. All of a sudden it was circulated in the news and everywhere else. The president at the time talked about it, that all that needed to happen was that enough people would get infected that we would develop herd immunity to the disease naturally. And I remember when that started circulating, and I thought, can anyone name a disease in the past that has been essentially taken care of and neutralized by herd immunity? And the example I gave back then, this is 2 years ago, I was talking to people about it, was polio. We had polio endemic for 70 years. Polio is highly transmissible. It has a very large fraction of people who were infected with polio virus who never show any symptoms. And yet in 70 years, we didn't develop herd immunity to it. So, give me an example of diseases for which in the past we've developed herd immunity and they become not a problem. And nobody has ever been able to give an example. Sometimes they'll say the flu, which makes no sense to me at all. You know,
Yeah.
given how many times we get the flu, if we're immune, why do we get it all the time? So you know, it was another one of those things. And another thing that kind of emerged was this notion that COVID cases and COVID deaths are systemically over-reported as opposed to underreported. I don't know if you remember, but there is an oncologist at University of California, San Francisco, Vinay Prasad, who came out and wrote that basically all of these COVID restrictions that we're seeing are based on inflated cases and based on inflated deaths because governments use pandemics as a way to impose power and control for power and control's sake. And by the way, that's how Nazi Germany happened, you know, which caused quite a bit of a ruckus since nobody can remember any pandemic that Hitler used as an example, as an excuse to seize power. And at the same time, if a pandemic was a great way to seize power and establish a dictatorship, why didn't Trump do it? You know?
Yeah.
And instead, what we see, and so this myth that the government was overstating COVID cases and overstating COVID deaths as a way to maintain power is ridiculous on its face, because all that we have seen, again, both federal administrations, Democratic and Republican, as well as basically every single state government in the nation, whether it's a Democratic governor or a Republican governor, has bent over backwards to find ways to undercount deaths and cases.
Yeah.
And there's a systemic bias in the United States. We have deaths that occur in hospitals. Typically, when a death occurs in a hospital, the death certificate, along with the causes of death, is filled out by either an attending physician or someone empowered to do that within the hospital. But if a death occurs outside the hospital, a very large number of death certificates are filled out by county coroners. And in the United States, we have a system of elected county coroners. So for instance, in the county I live, Monroe County, Indiana, we have a county coroner. County coroner is up for election, every 4 years.
Right.
The county coroner typically belongs to the same party that is dominant in the county. Most counties in the United States voted for Trump. Most counties are dominated by Republican politics. That's because most counties are small. That's not the same thing as saying that most people voted for Trump, and I'm only bringing up Trump to emphasize the Republican Party. But the fact is that most coroners in the United States are elected Republicans. And we know, and the reason why we know this is because they tell us that overwhelmingly Republicans are skeptical about COVID. They believe that it is overcounted. They believe that the risks are overstated. And they also believe that it's being pushed by various individuals as a means of control, as Vinay Prasad said. And so you have to ask yourself, if a Republican coroner comes across a person who, let's say, died at home, maybe they were older, maybe they were younger, and it doesn't suspect any foul play. It appears, that from talking to people around the person, their friends, their family, etc., that they had fallen very ill with something that looked like the flu. The coroner is not going to do any work at all to determine the exact cause of death. They're not going to order COVID test on the body, particularly because often the families will resist that very heavily because the families themselves were in denial that the person died of COVID. So they don't want to be proven wrong. And so it's just as easy, and it's perfectly legal for the coroner to put down the cause of death as respiratory distress. So that's what gets reported on the death certificate. And that death certificate then gets filed with the state authorities, and the state then forwards that death certificate to the CDC. And all the CDC sees on the death certificate is elderly male died of respiratory distress. Well, elderly males die of respiratory distress all the time, so that sounds good. You know, we'll mark it up as a death, but we won't mark it as a COVID death. And that's just the way it happens. And we see that on this slide I've got here. There are basically three different maps of the exact same thing. The map in the lower left-hand corner, the one that's a lot of black and orange, that's maps of counties in the United States that have very high death rates from reported death rates from COVID. And you'll see it's really very concentrated both in the rural South as well as areas that are traditionally populated by people of Hispanic descent and Native Americans. African Americans, Native Americans, and people of Hispanic descent, as well as people who are lower income, are extremely disproportionately hit by COVID. And there's, undoubtedly a large number of socioeconomic factors to that. And they also tend to be to live in places where COVID is more likely to be underreported than other places. So if you look at the kind of bluish map in the upper right on this slide, that's a map of where the number of reported deaths from COVID is significantly lower than the number of excess deaths recorded in the county. Excess deaths are just simply the number of deaths more than what would be expected. So if you have a county where normally every April it has 100 deaths, if this April it has 200 deaths, then it has 100 excess deaths. Now, if that county also said, well, we had 2 COVID deaths, well, now you've got a gap of 98 deaths between what you expected and your excess. And what that suggests, at least, is that that's a county where there were a lot of COVID deaths that happened that didn't get counted as COVID deaths. And so again, you see the same pattern where the places where it looks like there's been a COVID undercount also correlate with the places where there have been, in fact, a large number of reported COVID deaths, just not enough. And then you also see a correlation with income. And that's the map on the lower right hand. There is a large correlation between COVID underreporting, particularly in areas that have large minority populations and that are less affluent. So, and more affluent and lower minority populations tend to have much more accurate COVID reporting.
Yeah, you also see, I think it varies a lot. There's also upstate Michigan, which is primarily white and less affluent, and then also in Montana, looks like they have very high death rates. But
and a lot of that in Montana is based on Native American populations. So I mean the effect on Native Americans is one of the greatest underreported stories of all. McKinley County, for instance, in New Mexico, is one of the youngest counties in the entire United States. It is predominantly Native American, and it has a staggeringly high death rate from COVID. It's one of the top 15 counties in the entire country. And again, it's a very young count. Most people are in it are very young. They're also Native American, and it's had just a terrible death rate. All the counties that you see in black on my map down in Arizona and New Mexico are basically predominantly Native Americans. So basically, just to kind of to sum up this slide, there was a myth that we were overcounting COVID. That it continues to today, in terms of COVID cases and COVID deaths. But in fact, there is no bias to overcount. It is in essentially no one's interest, not politicians, not health officials. Nobody has any interest. Nobody benefits from overcounting COVID deaths and hospitalizations and cases. There's substantial benefit that accrues to a number of people in different occupations, politicians, most of all, to deliberately undercount. And we've seen this, we see this particularly where they can get away with undercounting, and those are areas that are predominantly politically disenfranchised and economically marginal. In other words, they undercount the most where people have the lowest, the least power, if you will.
Yeah.
Kind of touch on this. It is, in my mind, it is a deliberate form of class warfare. A lot of people, when they hear the term class warfare, they think of Bolsheviks throwing out the czar. This is actually kind of the class warfare in the other direction. It is a warfare of the upper classes against the lower classes. It is warfare of the powerful punching down, essentially. Not the powerless punching up. It is the powerful punching down. And we are now hearing calls to do things like take masks off of kids in schools to make sure that there are no, I won't call them restrictions, I will call them COVID protections. Putting a mask on a child's face is protecting them against disease. It is not a restriction. Ventilating classrooms, ventilating workplaces, none of these are restrictions. They are protections. But there's a large and very vocal and very well-connected group of people that are overwhelmingly unbelievably wealthy, who are now very successfully making calls to remove the last vestiges of COVID protections that we have. And they are basically the only ones who are making those calls. Poll after poll after poll shows very strong support for things like hybrid learning, online learning, masks in schools, masks in public places, among minorities and among lower income groups. The only people who are calling to remove those things are people who essentially are invested in the status quo. There's a group called the Urgency of Normal. And you and I talked about this a little bit earlier, but their message or their motto is, we urgently need to get back to normal. And they often use children as a rhetorical device in this, that we are causing untold harms to children by requiring them to wear masks in schools. A whole lot of assertions for which there is absolutely no data to support it. And the way that I think of it is what they're actually arguing for, what they're actually telling us to do. And again, they're very well represented. They get to testify to Congress, they get to go on TV, is how urgent it needs to get back to the old status quo. Now, the status quo was a set of economic arrangements that we had pre-pandemic that overwhelmingly benefited the rich and the powerful. That's why it's the status quo. That is the definition of status quo. And what that old status quo did was it benefited the rich and the powerful at the expense of essentially everyone else. So what they're telling us when they say it's urgent to get back to normal is that it's urgent to get back to the status quo. And that status quo is one of income inequality, political disenfranchisement of the powerless, of class warfare and class division. And when the people who were harmed by that status quo are asked through polls, they overwhelmingly say, no, we don't want to go back there. But the problem is they don't have a voice. They don't have the connections to Congress. They don't have the spots on MSNBC on Ari Melber's show. They're basically unseen and unheard. And so it appears to most people that there's a broad-based consensus that we need to take masks off of kids and that we need to return to in-person working. When in actuality, there is no such consensus.
I guess just if I could raise maybe just one thing, I think just I agree with the points that you made. I think that it is really class warfare, in a downward direction, or you could say a social counter-revolution that's being, it goes back decades. I mean, as you said, all the status quo, before the pandemic was, decades of ever-growing social inequality, the impoverishment of, the vast majority of the working class. And I think, we've seen that really intensified during the pandemic. I mean, you have a situation where the billionaires in the US have increased their wealth by over 70% as of October of last year. They amassed over $1.7 trillion in the space of, I believe, just 18 months. While, tens, hundreds of millions of Americans are struggling to get by, suffering, repeated infection. Nearly 1 million have died, or over 1 million if you look at the Worldometer's figures, and the Economist estimates, 1.2 million excess deaths. And it's not just in the U.S., but on a world scale. This has just been a complete catastrophe. We wrote on it earlier this week, but there was a major study published last month which found that global life expectancy has declined by nearly 2 years during the pandemic, which is the first time that's happened since World War II. Yeah. So it has been a social counter-revolution against the working class, of all races. And I think the urgency of normal crowd is fairly diverse. I mean, they have Leanna Wen is one of their spokespeople. It's just I guess I would just say I think it's not just white people, but it's this upper middle class, politically connected layer, and really coming from the ruling elite, the political establishment. And there's also people like Nicole Hannah-Jones has tweeted about supporting school reopenings. So it's I think it's fundamentally a class issue. The entire pandemic. There's actually a report published a few days ago by the Poor People's Campaign. I don't know if you saw that, but they go into this, that the sort of the fundamental factor behind people suffering from the pandemic has been their income. They point in addition to districts like the Bronx in New York City, one of the worst affected counties was actually Mingo County in West Virginia, where 52% of the population lives under 200% of the poverty line, and I think like 90% of the 95% of the county is white. So it's No,
you're absolutely right. It's not just white people against everyone else. To the degree that race and economic status are intermixed is the degree there. But yeah, there are people of color on the Urgency of Normal's advisory team, right? So, but in my mind, they're kind of the exception that proves the rule. I'm laughing to myself a little bit because I think I've heard you use the term elite, referring to this group of well-connected and politically connected individuals. And I would be remiss, I have a friend on Twitter who reminds me of this all the time. Elite implies a certain superiority of intellect. And there's absolutely no evidence that these people are elite in any sense of having a superior intellect or superior intelligence. And in fact, everything that they do suggests to me that they are kind of united in being remarkably stupid. They even, the call to, as you pointed out, the pandemic has been a profit boom for the rich and the powerful. So they should have less interest in going back to the old status quo than anyone else, given how it has, in very many ways, even amplified the old inequities, and it has channeled more and more money to them. It has provided a bonanza of opportunities for grift and corruption that they are eager and well positioned to take advantage of, and they have. So I don't understand why they're advocating for going back when, as Vinay Prasad pointed out, if they had an ounce of smarts, they'd use it to put us all in permanent lockdown and enslave us, right? But they don't do that, which implies to me that they're not terribly bright, actually. And some of the mistakes in messaging that have come out belie that as well. They don't seem to be able to get out of their own way in terms of screwing up the message. And they are constantly saying the quiet parts out loud without even realizing what they're saying. So I won't call them elite. I don't think that they're particularly elite. I don't think that they're particularly smart. They are.
No, I didn't mean. Yeah, I didn't mean smart. I just, I meant ruling elite is sort of a term for, the financial elite, the wealthy. But yeah, I just meant they're affluent. I mean, they're clearly, they're totally reckless. I mean, we see it right now with the half of DC, half of the DC establishment has gotten COVID. They just had this super spreader event at the Gridiron Club. I mean,
and some of them for sure are eating their own dog food. Some of them believe what they say. There's no
absolutely
about that. So
they weren't wearing masks. They went to they had this event at the Gridiron Club where 600 people were maskless. Anthony Fauci was there, Rochelle Walensky. I mean, it's incredible.
Yeah. And what they are is they're not elite, but they are comfortable, and they don't want to be uncomfortable.
Right.
Any more than the rest of us do, but they're willing to do and say anything that they think will perpetuate being more and more comfortable into the future. And so they're not all lying. A lot of them believe it. And perhaps the only thing you could say about it is that they don't look at counterexamples to what they're saying, and they never doubt what they're saying, simply because they have no interest in discovering an alternate narrative, because an alternate narrative comes off to them as meaning you're going to be less comfortable than you are now. So that's why they perpetuate it. So in the summer of 2020, something came out called the Great Barrington Declaration. And to the public, it looked like something that was put together by three individuals, Sunetra Gupta, Martin Kulldorff, and Jay Bhattacharya, who, again, to the public looked like medical experts. Kulldorff is a public health person at Harvard. Sunetra Gupta is an epidemiologist, I think, maybe a virologist at Oxford, and Bhattacharya has an MD and works for Stanford. Stanford has played kind of an outsized role as an institution throughout this entire pandemic. It's the home John Ioannidis, as we were talking about earlier. It's where Jay Bhattacharya came out. It is where Trump's COVID czar, Scott Atlas, was from. And Stanford's COVID prognosticators tend to take a view of the pandemic, not from a public health perspective, but from an economic perspective. And it's amazing how much of the response to COVID has been driven by economic cost-benefit calculations as opposed to public health calculations. Anyways, the Great Barrington Declaration was actually written by a team at something called the American Institute for Economic Research, which is a kind of a libertarian right-wing think tank whose job it is to publish white papers and working papers advancing the perspective of an investment firm that manages the investments of a number of very, very, very wealthy individuals. And so AIER's interest is in publishing white papers and other kinds of things that have a side effect of increasing the value of its patrons' investments. It's very much a kind of a vehicle for that kind of thing. And essentially,
it's also funded by the Koch Foundation.
It's funded by the Koch Foundation, as you know. Koch Foundation funds a lot of stuff, and they certainly have no objection to funding these people because they are ideologically aligned. And that's the way really that people should view the Great Barrington Declaration. It's not a public health statement. It's not a statement about a management of pandemics or epidemics. It's an ideological manifesto, if you.
We called it a manifesto of death. Was the term that we used?
It's an ideological manifesto, again arguing for the status quo in order to benefit the bank accounts of people who are already very, very wealthy. And what it said was that we should promote herd immunity. This is before vaccines. And because herd immunity will, again, they never gave any example of a past disease that had been eradicated through herd immunity, but they just threw it out there and hoped it would stick, and it did stick, and it stuck very hard. But that, and again, playing on the theme that COVID only impacts old people, what they said was essentially young people are immune to this. In particular, children are immune to COVID. They didn't use the word immune, but it's very difficult to read what they said, come to any other conclusion. And so they said, basically, what we need to do is get as many of the immune people infected as fast as possible. And the primary demographic of immune people that we should infect as fast as possible are children. And if we do that, if we get everyone who's immune infected, then we'll have herd immunity. And on our path to herd immunity, the only thing that we really need to work on is we need to protect the vulnerable. They never defined who the vulnerable were, but if you read what some of them have said, and written about, you come to the understanding that when they say vulnerable, they mean people over the age of 70 or 80. And that everyone else is de facto immune. So if we just make sure that nursing homes, and again, most people who are 70 don't live in nursing homes. Yeah. Most people who are 70 live at home. I think over half of people who have who are 80 or older live at home, like my mother. So there was this kind of idea that only old people are vulnerable and all old people live in nursing homes. So all we have to do is protect the nursing homes and let it rip everywhere else. Then we get herd immunity, and then it's great. They called that focused protection. I like to call it focused infection. because these are two terms that mean the exact same thing. If I'm concentrating on not infecting one group, that means I'm also concentrating, and they said they wanted to do this, another group. So the essence of the Great Barrington Declaration can be boiled down to a concept of focused infection, particularly in children, using schools as the main transmission vector.
Yeah.
Now, they hate it when I say that, and Jay Bhattacharya actually retweeted a tweet of mine where I said that, and he was full of outrage that I suggested such a thing. But there's no other conclusion that you can come to when you read their declaration. It specifically talks about children.
I have it here. The key paragraph says, quote, "The most compassionate approach that balances the risks and benefits of reaching herd immunity is to allow those who are at minimal risk of death to live their lives normally, to build up immunity to the virus through natural infection, while better protecting those who are at highest risk. We call this focused protection."
Yeah.
Quote.
Yeah, and I call it focused infection.
Yeah.
I mean, I won't make you do it, but anyone should read that paragraph again, and just the only change being we call this focused infection, right? Yeah. It's the exact same paragraph, either way. So, yeah. And they also they specifically talk in the declaration about how children are particularly immune or not vulnerable, as they say. So they really, really, really don't like it when you basically read their own words back to them. It's
a key. They say, we know that, quote, "We know that vulnerability to death from COVID-19 is more than 1,000-fold higher in the old and infirm than the young. Indeed, for children, COVID-19 is less dangerous than many other harms, including influenza," end quote.
Yeah, which is
total lie.
Flat out not true.
Yeah.
Right. So I'll talk about that in just a little bit. But one of the things, just so I don't forget, but one of the things that you hear often is about how much lower risk COVID is in children than in adults. And that's often used as a way to minimize the risk of COVID to children. But as I was saying at the beginning of this, that's true about every disease. And so you really kind of betray your agenda when you open your mouth. I'm not talking about you, Evan, of course, but in general, when you open your mouth and you say, well, it's not as bad as in kids as it is in adults. That's attempting to frame it in an inappropriate way. What you should be doing is saying, well, compared to other things that kill, injure, or harm children, where does COVID rank?
Right.
And the answer I can give you to that is that COVID is the deadliest disease of all diseases in children. COVID has killed in 2 years somewhere between 1,000 at an absolute minimum and probably much closer to 5,000 children. 5,000 when we look at the excess deaths.
In the US.
In the US, right? So I'm very comfortable saying there's no way it's 1,000, right? The highest official reports out of the CDC say it's around 1,500. But when we look at pediatric excess deaths, the number looks closer to 5,000. This is Mark Bevand, whose work has been cited in the Financial Times, says it's somewhere between 5,000 and 10,000 children. And again, even more than adults, children are likely to be undercounted with regard to COVID. So there is no other disease that claims that, not even all forms of cancer, that claim that many children every year or every 2 years. And in fact, in the last 2 years, we've had, as of today, I think, 15 deaths from flu in children. We've had a minimum of 1,000 deaths from COVID. Now,
Yeah.
people will say, oh, well, the last 2 years for flu don't count because it was so low, which always, gives me a mix of laughter and horror, because you then say, well, gee, why is flu so low in the last 2 years compared to what it normally is? Normally, flu has a reported pediatric death rate of around 130 kids a year.
Yeah.
Again, COVID has killed in the last 12 months 1,000 kids minimum. So even if we compare historic flu rates to current COVID rates, there's about an order of magnitude difference. So anyone saying that COVID is less of a threat for children than flu simply doesn't know what they're talking about, or they're lying, or both. And I might get into that a little bit later. But again, the takeaway here is that compared to other things that kids die from, particularly other diseases, including cancer, COVID is the deadliest. I'm on, I think about this a little bit. I mean, if I was faced with some kind of a Sophie's choice of having my child injected with the polio virus or COVID virus, I'm not sure I wouldn't pick polio.
Yeah.
It's not clear to me at this point that polio is a whole lot worse and might actually be milder, to use the term, in a child than COVID. So kind of coming out of everything we've been talking about, the need to quote unquote the urgency of normal, the undercounting, political expediencies, that has faced schools with enormous pressure to resume in-person instruction. And my son's school, for instance, returned to in-person instruction in August of 2021. First week in August is when his school went back. Most schools in Indiana did as well. A lot of the reasons for why schools are facing this kind of pressure is that the primary mission of schools, elementary schools in our country, does not appear to be actually educating, teaching fundamentals of education. It is a mechanism for a particular kind of socialization, that produces pliant workers, as well as it functions as daycare for very young children. And because we have such a high labor force participation rate in this country, we are driving more and more adult members of every family into wage employment by necessity. It used to be that you had, back in the 50s, the labor force participation rate was much lower than it is now. It was also a much better economic time. But we often hear on the financial channels this talk of labor force participation rate. Labor force participation rate is simply that percentage of able-bodied adults who could work at wage employment who are. So back in the 50s, when you had one individual, almost always the man, who was the breadwinner, you had another individual in the family, the woman, the spouse, who remained at home and performed feats of home economics, as we said, including the raising of children. And there was there was a certain resiliency here. Now, of course, there are all kinds of issues related to this involving women's right to work in the workforce, and that's very real, and I don't want to take away from that. But what I do want to say is that back, decades ago, the labor force participation rate was much lower than it is now. Now, most suburban families, or at least a very large portion of them, are dual income, dual earner families. Both the wife and the husband go to work during the day. which leaves no adults in the home, particularly in white homes, to care for children who can't care for themselves. And so we've switched that function to the schools, who operate as essentially large de facto taxpayer-funded daycare centers in response. Now, it's interesting, one of the reasons why we don't see as much pressure or as much urgency to return to full-time in-person schooling in minority and lower income communities is precisely because those communities tend to be much more robust in terms of having multi-generational households. They may have an aunt or a grandparent living at home. And so they're actually, much better equipped to care for children outside of school. The need for having schools function as effective daycare is much higher among not just affluent white families, but affluent families in general, because affluent families tend to have both adult members in the workforce, and they also tend not to have other adult members of the family, like grandparents or aunts and uncles, also living at home. So they don't have that's one safety net they don't have. So that's why a lot of the pressure for opening up schools to in person comes from. The other is that there's a perception that schools provide essential nutritional services for children. Schools also serve as sentinel points for abuse of children. So if a kid shows up and it's been battered, it's obvious to the school officials what's going on, and they can send child protective services. So these have been arguments that have been pushed for why schools need to open up. The other thing is that the capital class, these bumbling elites that we were talking about earlier, desperately do not want parents staying at home taking care of the children. They want them back in their seats, in their cubicles, working, because that's what they're
Yeah.
And in fact,
factors.
Work from home is very toxic to anyone who runs a firm that depends on having workers be on site. We call those essential workers, and they're working at McDonald's, and so they're that. So there was a kind of a real push to resume in-person school. Not necessarily because that was better for children's mental health. It certainly was worse for their physical health, but because it essentially enables, or is a prerequisite for, quote unquote, return to normal. And by that I mean adults going to work instead of staying home with their kids. I saw this fairly acutely in my own experience with my son. I'd sent several letters to the school board, warning them first about the surge in pediatric cases that I anticipated with Delta in the fall. None of my letters were ever answered, and asking what the school was was going to do about that. Again, not answered. And then as Omicron started coming onto the scene, I did the same thing and predicted a wave of pediatric infections and cases in our school system. And in fact, that wave materialized, and our school system used to publish on the school system's webpage a daily count of all of the COVID cases in each of the schools. The school system has about 13,000 students, and they would publish those. And then literally at the height of the Omicron surge, when cases, the counters for the cases were, rolling forward like an odometer in fast forward, they made an arbitrary decision the day that I published the case numbers to take all that data away. And they said that they will stop updating the school system's COVID impact chart, including the counts of new cases in each of the schools. And the local newspaper came out with a front page article, and the title of the front page article was MCCSC, that's the local school system, relaxes COVID-19 protocols to maximize in-school instruction. Translation, we're no longer going to report cases because they're exploding, and that threatens in-school instruction. And in-school instruction is, as the superintendent said, the overarching concern. The overarching concern was not kids getting sick. The overarching concern was not kids getting sick and bringing sickness back home. The overarching concern, according to the school corporation, was simply damn the torpedoes, full speed ahead. And this is an example of them essentially saying, again, the quiet part out loud.
Yeah, we saw that across the, or we've seen that across the country, you know, ever since fall 2020, you know, the same arguments.
Yeah. Every time that it has increased, every time that the numbers have gone up, the more kids go into hospitals, the reaction is always the same. Not we're going to reinstate mask mandates, not we're going to go online for a little bit until this blows over. It's we're just going to stop reporting.
Yeah.
You know, and that's been the theme of what we've been talking about here this whole time. I want to give some examples of kind of, this is a correlation. It's not proven to be the causation, but it's really hard for me to ignore. From March 2020, essentially when the pandemic began, until September of last year, last fall, on average, about one child a day died from COVID. And that's pretty consistent. There are three different sources that I use for pediatric deaths. One is the American Academy of Pediatricians, and the other two are two different data sources from the CDC that I'll talk about in just a little bit. And all of them showed pretty consistently prior to September of 2021, between 0.7 and 1.3 pediatric deaths a day. Since September of 2017, the last 8 months, that has gone to 3 deaths a day. The lowest is 2.4, the highest is 3.9. The overall increased average across all three sources is 3.1, is that deaths have increased by a factor of 3.1 precisely, since the end of hybrid / online schooling and now.
Yeah.
So if that makes sense. Now, when I point this out, people say, oh, there's other confounding factors, and not all schools, some schools in Texas went in person back in the spring of 2021, like Texas, blah, blah, blah. And so that must be it. And there's just a tremendous amount of effort and energy spent to de-link the return of in-person schooling and the rise in COVID cases and deaths among children. It's amazing to me just how much energy people spend on that, when it's intuitively obvious, if anyone believes, as I do, in the germ theory of transmission of disease, that if you cram a bunch of kids with a bunch of other kids who aren't from their same family for 6 hours a day, 5 days a week, that's going to constitute a super spreader event every single day. And that we should expect cases and deaths to rise, proportionally. And here that's exactly what we see. Yeah. And so it's kind of an Occam's razor. I mean, you can say, well, it might be because, the wind was blowing a little harder in September and not as hard in October, or, any number of 1,000 different excuses for why this has happened. Or you can look at the simplest excuse, which is just that shoving kids into classrooms unvaccinated and without masks is going to increase transmission, because that's what it does with every other disease. So why wouldn't it with COVID? So
yeah, no, I think that there was a real pronounced shift in fall 2021. I think Trump initiated the back to school campaign in July 2020 with his infamous tweet that all schools must reopen in the fall. And we saw in the Republican-led states, they enacted that, and it was catastrophic. There were immediately surges throughout the South in particular, but anywhere where they fully reopened schools, in many cases without masks. And we did see surges in child deaths in those areas. But and then once Biden came to power, he pledged that would be his central domestic policy would be to reopen all the schools, and immediately that that was enacted. It began, they set the precedent in Chicago, and then that opened the floodgates. Philadelphia reopened, and then Los Angeles, Oakland, all the major cities, and it was a steady progression, and most parents, or many parents were able to choose, and they did choose to keep their kids at home that spring, so a year ago. But then in the fall 2021, most major cities did not provide a remote option. They basically compelled parents to send their kids into these war zones, and it was just, as you said, catastrophic. We saw, and we wrote on it every week on the WSWS, but the rise in cases during Delta was just staggering. It was the first time you saw, or maybe not the first, but it was a steady, week after week of over 100,000 cases. And, we saw record child hospitalizations, I believe by late August, early September. I think it was more than double the previous peak that had been recorded by the CDC. And then all of that was dwarfed during the Omicron surge, which I know we'll come back to later. But it really, this past school year has just been really horrific. And I think it's important to stress the role of the unions as well. Randy Weingarten went on a tour across the country and basically made that her central priority was to enforce the reopening of schools. And she's the head of the American Federation of Teachers, and basically refused to carry out any struggle against these school reopening policies, which began when Biden first came to office. She actually told the New York Times at the time she was spending 15 hours a day on the phone orchestrating with the White House, the CDC, and local union officials and mayors to orchestrate the school reopening campaign, and that's continued ever since.
Yeah, that's a great point. It's kind of a meme or a trope or whatever you want to call it, that the teachers unions were against reopening schools,
Right.
Where everywhere I see, that's the exact opposite of the truth.
Yeah.
I know. Well, first of all, teachers unions generally don't have the kind of power that people ascribe to them. They do have a certain amount of power in some locations, Chicago, California, I believe. But for instance, in my state, Indiana, teachers unions do not have the right to strike. And a union without the right to strike is not much of a union in my mind. And they have no ability to negotiate anything other than compensation. I was told this by the head of our local teachers union. They cannot negotiate working conditions. So a teacher in Indiana whose union says, well, we're not going to allow our members to work in unsafe environmental conditions, where there's a deadly pathogen, that is not something that's negotiable.
Yeah.
So any teacher who refuses to go to work because they don't want to get sick is subject to termination.
Yeah.
I
was just going to say, throughout the pandemic, in particular since summer 2020, we've our movement, the Socialist Equality Party, which publishes the World Socialist website, has fought to help teachers build independent rank and file committees to really, to carry out a fight against school reopenings. And really, I mean, the unions have essentially, become sort of these bureaucracies that basically just, they siphon off dues, and they're integrated with the Democratic Party, and they don't really fight. As you said, they accept that they can't wage strikes, and they don't they don't wage any serious struggle. And I think, Randy Weingarten is sort of the embodiment of this. She's a multimillionaire. Her salary's like $500,000 a year. And she's on the Democratic National Committee. And, she was sort of the linchpin of the whole school reopening campaign. But I guess I just wanted to stress there has been a lot of opposition among teachers. There's been, Facebook groups with tens of thousands of teachers that have formed to oppose school reopenings. Hundreds of protests, since summer 2020 against this, but it's been contained and stifled by, in large part, by the unions.
Yeah, and that's absolutely true. And I just want to again say this pernicious notion that schools, that teachers unions were behind schools not reopening is
Right.
entirely false. As you point out, the head of the largest teachers union in the United States is very pro reopening. My son hasn't been in school basically since November. I just yanked him out. It wasn't safe enough. And he's been ostensibly online, and the school system still pretends that it provides an online option, but the quality of the online experience in fall of 2021 to the present is nothing like the quality that we had last year. There's
Right.
no, the all of the infrastructure, all the technology that we built up to facilitate online instruction has been thrown away. And the online experience, and I've talked to a number of parents who've done the same thing as me, we all express that our kids who are quote unquote ostensibly online now are really struggling compared to last year.
Yeah.
And one of the things that happened was that the teachers basically refused to prepare the online curriculum if they weren't going to get paid more for it. And so the school system reacted essentially by treating students who are quote unquote online today as if they were just very, very sick. So it's as if, you have to go get their homework and their class materials from the school, deliver it to them in their sick bed, right? And then they have to make some kind of, attempt to fulfill their responsibilities and complete their coursework without having any interaction whatsoever with the teachers or guidance or shared experience with the other children.
Right.
And so it's while on on paper online still exists, in reality it doesn't at all. And that puts parents like myself and others in a very difficult position, particularly when the schools have also decided to simply stop reporting the levels of infection that are circulating. Right, we are essentially given a choice, if you want to call it that, of sending our kids into a situation of really unknown danger, or keeping them at home and trying to be supportive and watching them struggle, essentially without any support whatsoever.
Yeah.
So.
No, it's been deliberately sabotaged.
Yeah.
The whole online learning.
Yeah, and it actually was starting to work pretty well, I thought.
Right.
Right. And it had a lot of positives to it. And instead of preserving that and building on it and using it, this isn't the last pandemic. We should have at least warehoused it, but instead we've just thrown it all away. And it's all gone. All that work and all that hardship was for nothing. We talked a little bit about Omicron at the beginning, and how it was sold to us as mild, based on essentially anecdotal information that was coming out of South Africa that was not very well supported by any data whatsoever. And the collision between this false story of Omicron as a mild disease, and with the reality of what we started seeing happen in the United States, at least beginning around early December, and that's from a pediatric perspective, that started to manifest itself as just an unbelievable surge in hospitalizations and cases among children. It's kind of it's important to note that our surveillance of pediatric hospitalizations, cases, and pediatric disease is very poor in this country, and that predates the pandemic significantly. Again, children don't usually go to the hospital. And hospitals are generally places where older, sick adults go. And so there are actually very few hospitals to begin with that really have much of an experience with treating children. And what they also didn't have, and this predates the pandemic, was any way of meaningfully tracking and categorizing children in hospital, just because children in hospital prior to the pandemic was a rare thing. Less than half of all states, for instance, even track the age range of children in hospitals, which is why it's so difficult for organizations like the American Academy of Pediatricians to get reliable pediatric case rates for the nation, because half of all states basically don't even report it.
Yeah.
So we've always had very poor surveillance at the pediatric level in hospitals, but what little that we did have really started to start ringing all the, flashing all the red lights and ringing all the bells around December, and that threatened to cause a real problem. It threatened to cause reversals in the return to in-person schooling, threatened to cause all kinds of problems, around the holidays, et cetera. And so the administration, at this point, it's the Biden administration, using Anthony Fauci, in one of the most disappointing disappointments of his career, from my perspective, introduced this new concept of incidental hospitalizations, right? And the argument went, well, Omicron is mild, right? Don't ask us how we know that. We're just going to tell you that, and you're going to accept it. It's much milder than the others. And in fact, as Marty McCary and others said, it's nature's vaccine. Which
Fauci went on to say, we can, hopefully this will be our live virus vaccine.
Yeah. Fauci said it. Bill Gates said it. Everyone was saying it, which is just an obscene concept in the first place, right?
It's herd immunity. It's basically herd immunity.
It's herd immunity. It's I'm going to get immune by getting infected, which doesn't make any sense. But they said that they said, well, basically what's happening is it's really mild, but it's really transmissible, and that means everyone's got it. And the fact that everyone's got it tells you just how mild it is, right? And there was no evidence that everyone had it either, but they just said that. And so, of course, if somebody comes in because they've got a broken leg or they had an appendectomy, I think that's what Fauci said, they're going to test positive for COVID because everyone's got COVID,
right?
Which was not true. But it had the effect of providing a lot of rhetorical ammunition to those who wanted to deny the fact that pediatric admissions for COVID into hospitals were going through the damn roof, right?
Yeah. It was also it was a talking point of the far right. I mean, people like Marco Rubio had made these points. Many Trump,
everyone who did not want to face the fact that COVID was having a devastating effect on children jumped on that as fast as they could, right? Because it was a very convenient thing to be able to fall back on. They also started to kind of redefine what, and this is actually happened after December. It might have been much more recent. Is that they're now defining what it means to be hospitalized for COVID. And one of the ways that they're doing that is to essentially only count a COVID hospitalization as being caused by COVID if the patient is being administered one of a small number of essentially life-saving therapeutics. In Massachusetts, the definition is if they are receiving anti-inflammatories to shut their immune system down. Shutting down the immune system is very important in severe COVID cases because a lot of, if not most, severe COVID cases are not caused by the virus. They're caused by our immune system overreacting to the virus and causing what's called a cytokine storm, which is why when people who have an overactive immune system that is literally destroying their own body are given steroids to shut the immune system down. Right. In New Hampshire, they are the standard for being admitted to the hospital for COVID is being administered antivirals like remdesivir. So basically, you are not you are no longer in an increasing number of states counted as being hospitalized for COVID unless you have an extremely serious case of COVID. Otherwise, you're just counted as being hospitalized for something else, right? The flu, when it's obvious this is ridiculous. The other thing that happened is that there's an increasingly a move towards not calling a death from COVID unless it satisfies one or both of two criteria. The first criteria has got to be that COVID has got to be listed as one of the causes of death on the death certificate. That sounds reasonable, but if you remember earlier in this conversation, I talked about how frequently COVID is left off as a cause of death on death certificates. This is particularly true in pediatric cases. COVID is left off of, I won't say most, but a very large number of pediatric deaths from COVID off of the death certificate. And there's a number of reasons for this, including people just being busy and in a hurry to fill out death certificates and not wanting to do a lot of testing and just putting down, respiratory distress or sudden infant death syndrome is the cause of death or whatever. It is a felony to put down as a cause of death that the person did not actually die from. So if I'm a doctor and I know that somebody died because they got shot in the head, but I write down that they died because they got hit by a bus, and I know that that's wrong, that's a felony. But it is no crime whatsoever to omit causes of death. So I could be reasonably certain that a person died as a result of a SARS-2 infection that caused COVID, and that's what caused their heart attack, or that's what caused their stroke, or that's what caused any number of things. But I'm under no pressure to put that down as a cause of death. All I have to say is, yeah, they died because their heart stopped. Not that their heart stopped because of COVID, right? I haven't added a cause of death that wasn't true. I've just left one off, and that's not a crime. So a lot of states are moving towards calling COVID deaths only COVID deaths where the death certificate explicitly mentions COVID as a cause of death. And again, that's going to result in an undercount. Or they did not have a positive COVID test or a laboratory test confirming infection with the SARS-2 virus within 30 days of a positive test. And that's problematic. I'm going to talk about that also. But the point of this slide and what we've been talking about here is that, we saw earlier that cases tend to be undercounted. Now, especially with Omicron and the increasing amount of damage that it was showing, even though it was sold as mild, there are now very strong efforts to redefine what it means to be hospitalized for COVID and to introduce this new term of incidental COVID to explain why so many people are in hospital with COVID but aren't really there with COVID or something. as well as to actually start to now redefine what it means to die from COVID. And what we're doing is we're making it increasingly strict as to what you have to do to get counted.
Yeah, I think these are really critical points, and I think just the fact that this has taken place during the Omicron surge, I think, you know, as you've said, there really has been a pronounced shift, you know, especially since December 2021. You know, there were repeated it was clear Omicron was going to be catastrophic. There would be a massive wave of infections, but they adamantly refused. There's multiple press conferences where they said, we are not locking down. Go get your booster. You'll be fine. And just, you know, take it on the chin, basically.
Yeah.
And, you know, we saw, I think it's important, the point you raised about the rise in pediatric hospitalizations, that was very noticeable from the beginning of the Omicron surge. By mid-December, it was clearly peaking. It was going to surpass the already astronomical peak seen during the Delta surge. It went on to more than double it. And, you know, this is sort of, you know, this is a precursor to the broader surge of hospitalizations, or an early indicator. And they just, you know, I think that really, it's important. The point you made is important, that this sort of set in motion this whole process of falsifying the data. And, you know, I think it's been really horrific what we've seen over the past 4 months during Omicron.
I don't know. I'm sure you do remember, but there were reports throughout December of the National Guard being called into pediatric hospitals.
Yeah.
Right. Here in Indiana, Riley Hospital for Children up in Indianapolis, which is one of the preeminent children's hospitals in the nation, was talking about bringing the National Guard in, right? Because they were so busy treating kids that they didn't have time for doing, you know, some of the other things that they needed to do that they thought the National Guard could help them out with. And that basically went over with no fanfare whatsoever.
Yeah.
You know, and it's hard for me to imagine a world where we are calling the National Guard into children's hospitals to deal with the inrush, and it's essentially not news.
Yeah.
How does that happen? Right? You know, there was maybe a couple of stories in the papers about it, and then it just disappeared. And nobody, you know, there were no conversations at the school level or whatever about it. Hey, you know, maybe we should take a couple weeks break because they're calling the National Guard in to help with all the kids who are sick in the hospitals. Right? Never any discussion of that. That was not an option. Again, it was, you know, full bore ahead. And it was very pronounced during the Omicron surge, but I want to kind of point out that we have an established history of deliberately ratcheting down surveillance every time there's a big surge.
Yeah.
So this started, you know, if you remember the winter of 2020, 2021, you know, we had the largest surge to date of the entire pandemic. This winter surge was the second largest. In some states was actually larger than that one. But
in terms of deaths.
In terms of deaths, yeah. So they're pretty much neck and neck. But it was back in the winter of 2020-21 when some states began reducing the frequency with which they reported COVID cases.
Right.
So that started, you know, on January 1st of 2021, basically smack in the middle of that surge. 48 states and territories provided daily statistics on COVID. By 1 month later in February, that had dropped to 46. And by April of 2021, it had dropped to under 40. So in the middle of a huge surge, both in cases and deaths, is exactly when states started dialing back the surveillance infrastructure.
As thousands of Americans were dying every day.
So the response was to stop looking.
Yeah.
And we have a pattern with that because it plateaued for a while, and the number of states kind of doing surveillance remained fairly static until around January of this year, 4 months ago. In January, only 20 states of this year were still doing daily reporting. That number is now 8.
Oh, it's incredible.
Yeah, we have in the last week, an average of 600 people a day have died from COVID. And at the same time, we've reduced the number of states reporting daily COVID statistics to just 8. Again, a year ago, it was 48. So 40 states have dropped off, and that number is increasing. And in fact, as of today, roughly a quarter of all states provide no meaningful daily statistics whatsoever. They're reporting once, at most twice a week, which is operationally and tactically useless. You can't do any kind of forecasting or do any reaction to that. And we were sold that this was okay because, again, as we talked about earlier, cases don't matter. Omicron is mild. Everyone's been infected. Everyone's going to get infected. So we're always going to have a lot of cases. So no point in counting them because it doesn't tell you anything, which wasn't true at all. Basically, what this slide shows in these two upper graphs with the squiggly lines is the number of states reporting, number of counties, individual counties in the country reporting daily, or in this case on Sundays, which I use as kind of a marker. You know, if the state is reporting statistics on Sundays, it's working pretty hard at providing timely statistics. And what we saw is a collapse both in Democratic counties and Republican counties along the same lines. So I just wanted to kind of emphasize.
Really over the past year in particular, as you're saying, after the winter surge. A year ago.
Basically just they all went to not reporting on weekends, and it didn't matter, you know, what the political leanings of the county were. They all started doing it. Yeah. So that's what this shows here. So then we were told, okay, just pay attention to hospitalizations. Well, we already talked about how they are redefining what it means to be hospitalized for COVID, and they're making it much more restrictive. And the other thing that's happening is that the CDC is relaxing requirements that it put on hospitals to do reports. A lot of the mandatory reports that hospitals were giving to the CDC with regard to the number of COVID cases that they had, et cetera, were authorized under the emergency provisions of COVID. You know, COVID essentially established a state of emergency that allowed the CDC to tell hospitals, okay, you've got to provide us with daily counts. And now that the emergency is undeclared, the CDC has told hospitals, don't do it. You don't have to, or rather what they've essentially said is, you don't have to do it anymore. I will tell you that no hospital is going to is going to spend time giving the CDC information that the CDC has told them they don't have to give them. Right? They don't have time. They have no interest in doing that. So essentially what that said is that the CDC has intentionally blinded itself to having any kind of real-time or accurate look into what's going on at the hospital levels, even though the CDC just last month told us that the hospital levels are the important things now. And then they turned around and, you know, they pulled a King Lear and out vial jelly. They ripped their own eyes out. They blinded themselves, and they did that intentionally.
Yeah, it's also connected to the Department of Health and Human Services. On January 6th, they basically changed their reporting system. They no longer required hospitals to submit daily reports on COVID deaths that had taken place, as well as other key statistics. But the WFWS, we were the only outlet that reported on that and really took it seriously. But it was ended on February 2nd, and it's just part of this broader cover up. And that was actually, we interviewed a number of experts at the time, and that was multiple data scientists said that was the sort of most reliable data set for what how many people were actually dying each day in hospitals.
Yeah. Yeah, no, exactly. Yeah, it's just, I mean, it's unsettling the effort to which all levels of state, federal government, including the hospitals themselves, are working to not provide information that at the same time they tell us is critical.
Yeah.
No, it's willful. It's again the quiet part out loud. So we're losing visibility into what's going on. We've lost visibility into what's going on in cases. We're losing visibility into what's going on in hospitals, and we're starting to even lose visibility into death reports. We're starting to lose we've always undercounted COVID deaths, and now we're starting to really accelerate that undercount. One of the ways that we're doing that, again, I think I talked about this earlier, is by making it more difficult to die of COVID, even when you've died of COVID. You've got to have COVID as the cause of death on the death certificate. Again, that's often left off in legitimate deaths. And you've got to have, or you've got to have had a positive test for a SARS-2 infection within 30 days of death. Now, everyone hears that and they think having it on the death certificate sounds like a reasonable thing. It's not, for reasons that I've talked about. And the other thing is this 30-day requirement. The CDC published something I think around 6, maybe 9 months ago, where they spelled out the median number of days from symptom onset to death. Now, symptom onset is a little bit different than a positive test, but they're very highly correlated. And they said basically the median number of days between when you start to have symptoms, which is when you're likely to get tested for COVID, and dying, is 19. But that it had an interquartile range for someone between 50 and 64 years old, which is where I am, of 11 and 30 days, meaning 50% of deaths happen between 11 and 30 days after symptom onset. Now, they have set somewhat arbitrarily, a limit of 30 days from testing to death as counting for COVID. But we know that only 50% of deaths occur within 11 to 30 days. Now, we don't know what the tails or the heads of that distribution look like, but it is likely that a very large number, perhaps 25% of deaths, occur more than 30 days after symptom onset.
It seems likely it would probably be even higher, actually. I mean, I imagine less deaths happen within 11 days, but
right.
It's hard to know.
So intuitively, you would think that, of the other 50%, fewer would be earlier and more would be later. But we don't know the exact distribution there. But I think it's very safe to say that
a substantial number.
That at least a quarter of all deaths happen more than 30 days after symptom onset. And by setting the bar at 30 days, you're ignoring those deaths. And we saw this effect in Massachusetts. Massachusetts went back and retroactively eliminated from its official list of COVID deaths any death that didn't have COVID listed on the death certificate or didn't have a positive test within 30 days of death. Right. And they were able to eliminate nearly 4,000 COVID deaths off of that, which I think Massachusetts has had somewhere around 25,000. So 4,000 off of 25,000 is a pretty big chunk.
Yeah, they just did this in March, just this past month.
Yeah. And I saw that, and I did a little bit of investigation trying to find out what had happened, and that's what happened. Now, Massachusetts actually traditionally had done a pretty good job of actually counting COVID deaths as COVID deaths. In other words, there's not a large gap between reported COVID deaths in Massachusetts and its excess deaths.
Right.
And that's what this blue chart, which I've showed you before, kind of shows. The Northeast, the number of reported COVID deaths out of the Northeast are, fairly accurate. I think they're still an undercount, but they're real close, given that they're very close to the number of excess deaths. That completely falls apart across the South. The South has already been undercounting COVID deaths substantially. And if they move to this same standard, they're going to undercount even more.
Yeah.
So we're starting to lose real visibility into exactly the extent of the COVID pandemic. And the only check that's going to emerge out of that is if states start coming up with truly ridiculous numbers, low ridiculous numbers of COVID deaths that don't square at all with their excess deaths. Right? They're going to have to explain, well, if only 5,000 people died of COVID, but you've got 10,000 excess deaths, what do the other 5,000 people die of? Excuse me. So, but the problem with that is that the calculation of excess deaths takes a long time. So we won't really see that gap, the full extent of that gap, for another year or so. And the question is, how much damage will have been done in that other year?
Yeah.
The last thing I thought I would talk about is something that you guys have covered better than anyone else, frankly. And this is the issue of the quote unquote data tracker controversy. And you and reporters like Emma have done just, I think, a fantastic job of covering this. And I think you should get a lot of credit for that. But for people who are kind of just now tuning in, the CDC does not have one definitive database from which it draws information about deaths and causes of deaths and rates of death, et cetera. The CDC has a number of different databases that ostensibly all contain the same information, but that information is gathered, collated, curated, and massaged in different ways. And the reason why it's done is because the databases are used for different purposes. And so the way that you collect this information about causes of death, just as an aside, information about causes of death have traditionally been very difficult to gain. One of the places where we see this most readily is in the ascertainment of the disease burden of influenza. The CDC and nobody believes that the number of reported influenza deaths, for instance, or the number of reported influenza cases is anywhere close to the actual number of cases and deaths. So what's reported for influenza, just as it is for COVID, is a significant undercount. So the CDC, in fact, that's why the whole concept of excess death was invented. And the CDC has a very large bureaucracy and mechanism that is involved in looking at reports, influenza case surveillance, et cetera, and producing estimates of what the actual numbers are. The CDC does not do that for COVID, although it tried once back in October of 2021, and the estimates for COVID, particularly COVID hospitalizations, were so much higher than what they were seeing as reported that they shut that down right away. It was, and they have not attempted an estimation of COVID deaths, hospitalizations, or cases since October of 2021. And again, this feeds into the whole narrative of basically burying this data. With influenza, we did the exact opposite. CDC produces reports of influenza cases and deaths, et cetera, and hospitalizations that are much higher, usually by a factor of 2 from what's reported. The CDC does not do that with COVID, although it tried once, didn't like what it saw, and didn't try again. if
Yeah.
that makes sense.
Yeah.
But getting back to the data tracker controversy, there are two main CDC databases, if you will, where you can go and get information, particularly information about pediatric cases and deaths within the CDC. One is a database that's controlled and housed by the National Center for Health Statistics, NCHS. And that database is considered, if you ask the CDC, to be the more accurate of the two databases that I'm going to talk about. The other one is Data Tracker, but it has a number of limitations. The first limitation that it has is that it is based solely on death certificates sent to the CDC by the states. So that causes two major problems. One is it introduces a substantial lag. So if I die of COVID today, the CDC likely won't get my death certificate for at least 2 or 3 weeks. And then they will go through my death certificate on an individual basis and try and determine the cause of death from the death certificate. And sometimes they determine the cause of death was COVID, even if the death certificate doesn't list it. But what is much more likely to happen is if the death certificate doesn't list it, they will not record it as a COVID death. So the way that they process, the NCHS processes COVID information has an inherent undercount bias, because if the death certificate doesn't have COVID as a cause of death on it, as sent from the states, it isn't counted by the CDC as a cause of death. The other thing is that all of that processing takes time, which introduces a substantial lag.
Right.
And the lag gets worse the younger the person is. So again, as I said, CDC looks at each individual death certificate and tries to do some analyzing on it to determine what they call the underlying cause of death. Pediatric death certificates take much longer to process at the state level. So the CDC doesn't see a pediatric death certificate for much longer than it would see, for instance, my death certificate. The other thing is that pediatric death certificates, for reasons we talked about earlier, typically have much less detail about what caused the death than an adult one. So they're much more likely to not have a specific case of COVID, even when the child died of COVID, which will cause the CDC to not count that death certificate, that COVID death in a child as a death, even after the substantial lag. And it looks right now like the NCHS database is about 3 months behind for children. So what the numbers that you see in NCHS right now are probably reality as of around Christmas. Maybe the first of the year. So
what's the figure currently? Do you know?
The figure that they just revised it upwards by 71 deaths yesterday, I think it was, and it's now 950.
Yeah.
So it had been under 900,
which is close. That's close to what the data tracker was in late December. Right?
Yeah. So what I do is I look to what the data tracker said the number was with the current number, and that kind of gives me an idea of how far behind it is. Yeah. So the other database is what you just mentioned, the data tracker. The CDC is not terribly forthcoming about how they get the numbers that they have in data tracker. But my understanding is essentially it's based on the CDC having informal phone calls with state health departments several times a week and asking them, hey, how many people died? In what age range? So the data tracker tends to be the deaths in data tracker are not as vetted, as you would find in NCHS, which to me means that they aren't subject to as much of an undercount as NCHS. I think they're still an undercount, but they're also much more timely. They don't have there's a lag, but it's not the 2 or 3 month lag that we see with NCHS. It's much more contemporary. And so that started to cause a problem in March because the number, particularly of pediatric deaths in data tracker, was going up like a rocket ship, which is what we would expect from children who were infected during Christmas and January, with Omicron now starting to die in very large numbers. The fact that data tracker was going up so fast and the numbers were fairly staggering alarmed a number of people. It alarmed a number of people, particularly on the urgency of normal side, who had been pushing this false narrative that that children were immune to COVID, that schools needed to be opened, et cetera, et cetera, et cetera. And if it got out that kids were dropping like flies from COVID based on the recommendations of the urgency of normal folks, well, that was politically untenable. So one of them essentially got on the phone with the CDC and said data tracker is wrong, you've got to fix it. And you're, again, WSWS has reported on this extensively, and I urge everyone to go back and read your prior stuff on that. And the CDC essentially said, "Oh, no, we'll fix it." And overnight, within a few hours, the data tracker draws on a pool of total deaths. It had been drawing on a pool of, I think, around 850,000 deaths. And so as soon as they got the call from the urgency of normal folks, what they did was they artificially shrank that pool down to just a little bit over 700,000 deaths. So you can imagine if you're counting the number of children in a pool of 850,000 deaths, and then all of a sudden you shrink that pool to 720,000 or so, the count of children who died is going to go down. And that's exactly what happened. The CDC, as you guys have reported, still will not answer anyone's questions. And the BMJ has asked the question, you've answered the question, asked the question, the Guardian has answered the question, will not say the method by which they shrank that pool. But we do know that they shrank the pool because the number that they tell us that they draw from dramatically went down. And when that overall number went down, the number of dead kids went down as well. And that was then immediately seized by urgency of normal, the normal right-wing folks, the normal left-wing folks, as proof that the numbers in the data tracker were inaccurate, which wasn't true, but it was all the proof that they needed. And they've then been very successful at using that as a way to discredit the data tracker numbers. And unfortunately, some of the places that were reporting on the very large number of pediatric deaths using data tracker didn't push back on the CDC or anyone else at all on this, but instead just accepted their narrative and their description of a quote unquote opaque coding error as the cause of it, as that, and issued retractions and went back. And I think that did just a tremendous amount of damage regarding our understanding of the impact of COVID in children and our ability to meaningfully perform our adult responsibilities in terms of protecting children. So the crime here, in my mind, is not so much that the CDC restated its numbers using some criteria that it will not divulge, but that the media essentially became, with you guys being the exception, complicit accomplices in that restating, and allowed essentially a lie that COVID was not impacting children to not only continue to be perpetuated, but to be reinforced, which was just terrible. So yeah, I got something from one of the articles that Emma wrote here. CDC remains silent on its unexplained 25% cut in child COVID deaths. They still haven't explained how they did it. Now, interestingly, they made that correction in mid-March, around March 14th or 16th, I believe.
Yeah, I think it was the 16th.
Right. But the numbers that they were reporting in terms of pediatric deaths on March 1st are still lower than the numbers that they reported for pediatric deaths on April 1st. So what I'm saying is that month to month, there has been no reduction in pediatric deaths as reported by CDC's data tracker.
Yeah.
There was a correction in March that brought it down a little bit, but it's since recovered, and more so.
Yeah.
So, and of course, nobody's talking about that. The other thing that nobody's talking about is the fact that the NCHS data set is constantly revised. But unlike data tracker, it wasn't revised downward. It is in a constant state of revision upward. And in fact, just a few days ago, they revised pediatric death totals going all the way back to August upward. You know, and that tells you something else. One final thing I want to kind of say about NCHS and why the numbers that you see for COVID in NCHS are likely very highly discounted compared to reality is that you know, we've all heard of incidences of multi-system inflammatory syndrome in children, MISC.
Yeah.
Okay, the CDC tells us, because that's who they told news outlets like US News and World Report, that there have been 60 MISC deaths among children from COVID in the last 2 years, 60. If you ask the NCHS database how many MISC deaths there have been in children over the last 2 years, guess what it says?
So the single digits? I'm not sure.
Yeah, it's single digits.
5? I don't know.
It's 4.
4, yeah.
Right? So CDC is telling the news outlets that there have been 60, but the same database that the Urgency of Normal folks and others tell us is the definitive source of the true number of COVID deaths among children says there's been 4.
Right.
So if there's that much of a disconnect between the real number of MISC deaths and what NCHS is saying, then it is entirely reasonable to believe that NCHS's count of pediatric COVID deaths is similarly undercounted. If that makes sense.
Yeah.
Right? And that goes back to just how unlikely it is for a physician to put MISC as a cause of death on a child's death certificate, right? So, you know, more than 1 out of 10 times that a child dies of complications of MISC, it doesn't show up on the death certificate.
Right.
And in a similar situation, I don't think it's quite as badly undercounted, exists with COVID. So that's why we have to take the NCHS numbers of pediatric deaths as not as the definitive source, but as representing an ultimate lower bound. Yeah. Where the actual number is probably in excess of what data tracker even says, which I think is around 1,450. Yeah. Right. It's probably closer to that 2,000 to 5,000 range that I mentioned.
Yeah, I think just in regards to the data tracker, I think you've made a number of critical points. I think we can't know, precisely what process led to this revision, but I think the speculation that you made is entirely plausible. And it's just, I think it's important to place this, as you have, within the broader context of the cover up of data on COVID-19. That's really been, I think that, it's important to stress that there has been a qualitative shift during Omicron. It's been continuous throughout the pandemic, but, in the past 4 months, there's just been a, sort of whole of, the entire political establishment has moved in every state. And I think it's important to, situate this internationally. The same process has unfolded in Canada, in the UK, across Europe. most countries where they had some semblance of tracking and reporting, they've moved to cover it up. And so we have to see this within that context. But as you said, they have refused to answer the questions posed by our reporter Emma Arsenault. She's asked, how is the algorithm accidentally counting deaths that were not COVID related? Why did this affect only 26 states, and which states were involved? And a number of other critical questions. We'll have a link below the interview to this this article, and it remains unexplained. And I think the fact that the deaths have they're adding to it now, more and more frequently, really, indicates that these deaths did occur. And as you said, the NCHS data is the lower limit, and it's entirely plausible that it's far higher, as you said, could be as high as 5,000. And it's just, I think what you said, that it's critical that this has it sort of facilitated the response of the far right, the urgency of normal crowd, to try to minimize the impacts of COVID on children. And I think just the key point that we've been stressing is that that they should be doing the exact opposite. That we're now we're in the third year of the pandemic, and there should be a massive expansion of we have all these tools, we have an understanding of how COVID spreads, the potential to eliminate the virus, but it requires a whole of society approach, daily data from every state, every country. That's the only way that we can actually put an end to this pandemic and save lives and prevent the mass debilitation of children. And so that that's there has to be a massive expansion of data, not these efforts to cover up and these opaque deletions of 72,000 deaths.
Yeah, exactly. One of the things that I keep hearing as an excuse for winding down COVID surveillance right at the time when we should be actually winding it up is that burnout among state health departments. And I don't understand that argument, given that collecting statistics on cases and deaths is their job. Right. We're not asking them to do something that they don't already do as part of the job description. Now, I understand that maybe collecting them on Saturdays and Sundays, or several times a week, may add to the workload, but it's still the same amount of work. And it seems it should be trivial, and maybe the federal government could step in with some grants to the states and say, hey, hire half a dozen more people, until we're done with this thing, right? Then nobody has to burn out, nobody has to work overtime, and they just do their job as they've been doing it, right? What is your job? My job is to every day I go and collect COVID statistics and I report them to the CDC, and then I come back the next day and I do the same thing, right? That doesn't strike me as outside of the job description. So this just kind of shows the different sources for pediatric COVID information. And I get them from the two CDC databases that we've been talking about. This is Data Tracker. This orange line is Data Tracker. The gray line is the NCHS data, which I get through CDC's front end that they call Wonder, which is an acronym for something that I can't remember. And the other is the data from the American Academy of Pediatricians, which is the blue line. All three of these, as I kind of mentioned, measure slightly different things. It's my understanding that the AAP, American Academy of Pediatricians data, is not as comprehensive as some of the CDC's data, so it traditionally registers a little bit lower. For instance, 4 states do not reliably report pediatric deaths, and the AAP data, and one of those is Texas, so a large state. And the AAP data does not include that. So AAP is always going to show a little bit less than Wonder. The other thing I want to point out or show here is the Wonder data is only current through through the 1st of February right now. So that's part of the lag. But you'll see that there's kind of a broad agreement between all three data sources right up until right around September, October, and November of this year. And right around November, December is when data tracker started to really separate from the other two. And again, that correlates with Omicron.
Yeah.
And it correlates with the fact that the data tracker data tends to be much more tactical, tends to be much more real time. And so I think a large part of this gulf between data tracker, and this is the data tracker after the CDC revision. If you see that last little kink in the orange line, where it kind of almost goes flat,
Yeah,
that was the revision. But you can still see there's still an upward slope to it. But the gulf between the NCHS and BSS data and the AAP data and data tracker, I believe is caused by three factors. One is lag. Those other two just haven't caught up. They typically do catch up. And the other is the differences in what constitutes a pediatric death from COVID. And in the case of the gray line there, the Wonder NBSS line, it's having COVID as listed on the death certificate, which, as I've kind of gone into before, is much less likely on a pediatric death certificate than on an adult one. So for people who are wondering, there's kind of a fuzzy yellow line on there as well. That fuzzy yellow line represents the pool of total deaths from which data tracker derives its statistics related to the pool of total deaths that the CDC is reporting in NCHS, if that makes sense. So if the data tracker pool was equal to the NCHS data, that yellow line would be at 100%.
right.
Meaning they're both pulling from a pool of 950 at this point, 1,000 roughly deaths. It has been over time, the pool from which data tracker pulls has been getting closer to the true total. And that could account for some of its recent rise. But the point I want to make here is that even the data tracker's total of over 1,400 pediatric deaths is derived from a much smaller pool than the actual number of COVID deaths, if that makes sense.
Yeah.
Yeah, it's still under 90% of the real pool. So I just wanted to make that clear. It's been a real pleasure to be able to speak with you about this, though.
Yeah. No, thank you, Greg, for participating in the inquest. I think this has been something of a tour de force. We've covered a lot of of ground. No, I think you've touched on many of the critical issues surrounding the cover-up of COVID-19 data throughout the pandemic, which is obviously a huge topic. And I think it's important to stress from the beginning, this has been central to the response of the entire American political establishment, first under Trump and then under Biden, and at this point by every state government. We discussed it, but I think the Great Barrington Declaration and the strategy of developing herd immunity without a vaccine was entirely predicated on the suppression of data and the falsification of science. And as you reviewed, really central to this were the lies that were propagated about the impact of COVID-19 on children and the role that schools play in viral transmission. And I think the points that you've made about the what's taken place during the Omicron surge are critical. There's been a concerted effort to manipulate data, to wind down critical dashboards, across the entire country, and to cover up COVID infections, hospitalizations, and deaths. And it's really been, I think what we've seen is really the coming together of the herd immunity camp with what we've identified as the mitigationist camp, or those who claim to be seeking to suppress the virus and ultimately end the pandemic. I think that's just been completely exploded during Omicron, and now they demand that society live with the virus. They falsely claim that it's endemic, and they've just set up society for perpetual waves of infection and death. And American society is now totally unprepared for the BA2 surge, which has already begun, and whatever variant evolves next. And I think it's clear that all of this really amounts to a monumental social crime that's been committed against the working class. And as we've said, it's part of an international process. And that's really the aim of the Global Workers Inquest, is to uncover these crimes, how they've unfolded throughout the world, and really fight to politically educate and arm the working class, the international working class, with an understanding of how this has happened, why, and what has to be done to stop the pandemic. So thank you again, Greg, and I encourage everyone watching today to share this video widely, and to fill out the form below if you would like to participate, if you're interested in participating in the inquest. So thank you.
Thank you.